So I think, Kay, we can start now.
Okay.
Thank you.
Thank you. It's a pleasure to chair the seminar today. I'd like to introduce our speaker. She's Mr. Johannes Bellhammer, who's completing his PhD at the Technical University of Munich in Germany in physics, working with Franz Pfeiffer, Daniele Pfeiffer, and working on new methods for reducing the dose in medical imaging using AI. With that, I'll pass over to Johannes.
Thanks for the introduction and thanks for having me. I'm also not that used to Teams, so let's see if I can get it right with sharing. Okay, can you see?
Yes.
My first slide. Oh, that's awesome. Okay, so basically, I wanna start with this talk with two images you don't want to see, at least not when it's a CT scan taken from you, because you actually see here two diseases on one image. Well, here we go. On one image, on the left image, you can see a hemorrhage here, very easy visible, and also like a smaller, more subtle one in the ventricle here. And on the right, you can see a pulmonary embolism at one of the vessels here in this darker area. But of course, if you have these diseases, you would like your doctor to diagnose you as best as possible. And then, of course, you would want to have such nice CT images where even people not trained at radiology can easily spot that there's something wrong. However, as most things in life, things come at a price. So in this case, the price is radiation dose. And in this talk, I want to talk about how we maybe are able to reduce this dose and investigate what impact that has.
I think the microphones have gone muted, Johannes.
How's that? Can you hear me?
Can you hear me again?
Now, yes.
Yes,
Okay,
yes, now we can.
All right. How much did you miss?
Maybe 15 seconds?
15
Maybe
seconds.
start
Okay.
slowly.
All right. Yeah. So basically, I want to divide this. No, I want to divide this talk into 3 chapters. In the first chapter, I want to talk about Sparse-View cranial CTs, and the second one about Sparse-View CT pulmonary angiograms, and in the last part, I want to talk about the things I've been done here at Monash about low-dose region of interest phase contrast CTs of calf lungs. Okay, but first about Sparse-View cranial CTs. A little bit of medical background. So intracranial hemorrhage is a pathological bleeding within the cranial vault, which you can see again very well in a CT scan. This accounts up to 15% of strokes with a quite high mortality rate of up to 40%. And for an ideal outcome, a rapid and accurate diagnosis is absolutely crucial. And for that, again, a CT scan is very well suited. However, a single CT scan has around 2 millisievert of dose, which is around half the dose you get through natural sources within a year. And one way to reduce those is Sparse-View CT. So in Sparse-View CT, what you do, quite simple actually, in a normal CT, you just go around, acquire projections, and then reconstruct them to get your CT reconstruction. And in Sparse-View CT, you just acquire less projections. So you kind of undersample your measurement. This, of course, reduces dose, but on the other hand, also introduces artifacts in your Sparse-View reconstruction. And we went ahead and wanted to investigate, okay, can we train a network which gets your undersampled CT reconstructions as input and the full view reconstructions as output, and kind of predicts from the sparse sampled reconstruction the fully sampled one and thereby reducing the artifacts. And for that, we use the unit architecture, so quite standard CNN architecture, and we compared this method also with an analytical total variation-based approach.
Oh, did you go out?
And for training, we used the public data set, which was published by the RSNA, consisting of like 25,000 labeled cranial CT exams, and they were all labeled on the different subtype of intracranial hemorrhage present in the image. And then we simulated our Sparse-View data by forward projecting the CT reconstruction. And then for the full view reconstruction, we reconstructed 4,096 views. And for the Sparse-View constructions, 64 to 512 views. And here are already the results. So you can see, again, the image from the beginning, reconstructed with a lot of views, and you can nicely see the two hemorrhages. And as you reduce the dose and use less and less projections for the reconstructions, the image quality drops quite drastically. So you can still kind of see the two hemorrhage regions in the 512 view reconstruction, but as it gets sparsier, it's quite difficult to spot. When you take these images as an input and try to reduce the artifacts with a total variation-based approach, you can see that you can actually get quite nice results down to around 256 views. But as you drop lower, artifacts start to appear again, and you can not really, at least here in the 64 view reconstruction, it's hard to spot anything. And when you look at the results from the trained network here, you can see that the artifact reduction works also quite nice down to 256 views, but also quite nice at 128 views. But of course, if the input gets too sparse or has too many artifacts, then the output is also not that good, and it kind of creates this blurry region. Of course, I could also calculate some nice fancy metrics on the different predictions or the different denoised images, but in the end, they don't really matter, in my opinion, because these images have a very clear purpose, namely, can you spot the hemorrhage or not? So we thought for how to quantify that, we trained a classification network because our data set was labeled. So we took 3 neighboring slices as an input and then trained in this case, efficient network to kind of predict if there is a hemorrhage or not, and if so, which kind. And then we fed our differently subsampled data set into the network with and without artifact reduction to have a look how the impact of this artifact reduction, how that impacts hemorrhage detection. And this is the area under the receiver operator characteristic curve. I hope you're all familiar with the receiver operator characteristic curves. If not, I can quickly explain. So basically, the network outputs a number between 0 and 1. And then you can define to get a binary classification. So hemorrhage, yes or no, you define a threshold. And then when you just go through the threshold, you get different specificities and sensitivities. And you get kind of a curve. And then you can just calculate the area under this curve, and higher basically means better performance. And here in this graph, you can see that as you reduce the number of views, the hemorrhage detection performance drops down quite well. So in the blue curve are the raw reconstructions, and especially after like 512 views, the hemorrhage detection performance drops quite a bit. When you reduce the artifacts beforehand with the total variation-based algorithm, then also the performance drops, but not as fast. And with unit-based artifact reduction, it stays on quite a high level down to 256 views, and then drops further off. So this curve just says or investigates the performance, is there a hemorrhage or not, but you can do the same with the different subtypes. which we did. And in essence, the story of all the subtypes is kind of similar. The only exception a bit is the epidural case, where you can see that in general, the classification performance is just worse. The reason for that is probably because this case was not that much present in the training data set, just like a few hundred cases, while the other cases had like a few thousand examples. And the data set, so it kind of makes sense that the network hasn't learned that well to classify the subtype. We also wanted to understand a bit what is the reason actually, why does the classification performance drop? And for that, we calculated saliency maps. So one of these saliency maps you can see on the top. In essence, what that is you have your classification network, which predicts you a certain class. So in this case, hemorrhage, yes or no. And then you can kind of wiggle around with your class prediction and then back propagate this wiggling, or you could also call it this gradient, back through the network, through the input, and have a look which input pixels were the most influential in the predicted classification of the network. So in a way, it's you can kind of investigate which were the, according to the network, most important pixels for the classification result. And here for our fully sampled images, we can see here's again the two hemorrhages that the network focused exactly on these two regions, mostly also here, but down there, but I guess that's all right. But again, mostly on this very bright hemorrhage, which is kind of what you would expect. And when we calculate the saliency maps now on the subsampled images, we can see that it still works quite well down to 256 views, but then it kind of loses the focus on where to focus. Loses the focus where to focus. And when you reduce the artifacts beforehand and then calculate the saliency maps here, we can see that actually this focus stays on the diseased regions quite a bit better. So this is only like one qualitative example, and we wanted to quantify that a bit. So we took 100 hemorrhage cases, manually segmented the hemorrhage region, and then calculated the saliency map ratio of the saliency map values inside the mask divided outside the mask to see if, well, we see kind of a more statistical trend. And these ratios for different levels of subsampling, for the raw FPB reconstruction and for the reconstruction with the unit artifact reduction, you can see here. So in blue, we can see that this, again, what we just saw, basically this focus on the diseased region falls off when you reduce the number of samples, but when you reduce the number of, when you reduce the artifacts beforehand, it kind of stays more focused on the actual pathological regions. And that kind of concludes the intracranial or the cranial CT part. So this worked quite well. So we wanted to investigate also some lung images, namely CT pulmonary angiograms. And again, a quick medical background, what is a pulmonary embolism? So basically in your body, it can happen that there forms a blood clot, mostly in like the veins in your legs. And when this blood clot gets loose and travels through your stream, it can kind of clog your blood vessels. And when this happens inside the blood vessels in your lung, then this is called a embolism. And how you investigate that is you introduce contrast agent into the blood vessels in the lung. And then you can see these vessels very, very brightly, which is in essence the iodine. And here you can see it's like inside the vessel, the outside is bright. So we have a blood flow there, but the inside is dark, which means there's probably an occlusion there. And again, very well suited to to detect this disease, but we wanted to investigate how this detection performance changes when we do some sparse sampling, some dose reduction, and then try to get rid of the artifacts again. So we went in our local hospital, so the Klinikum rechts der Isar. This time didn't use a public data set, but rather compiled our own data set. So we went into our clinical storage and archiving system, searched out cases which were investigated for pulmonary embolism, and then split them into like training, validation, test, and split and also researched some patients for a reader study. And in essence, we did then the same thing as with the cranial CTs, undersampled them, trained a unit to predict the full view, the full view reconstruction, and here are the results. In the full view reconstruction, you can very well see one of the embolisms here. And as you reduce the number of projections for reconstruction, image quality drops again. And when you reduce these artifacts again with the unit, the image quality improves. And apparently, or I think also the detectability of the embolism. For example, here in the 64 view case, it's like hard to spot in the sparse sampled reconstruction and a bit better in the prediction where the artifact is going to be reduced. We also did the automated detection analysis again, and in essence, quite similar results to the hemorrhage case. The only thing that was a bit surprising is that the network kind of scored perfectly down to 128 views, and then the detection performance decreased again, decreased a bit faster with the raw FPP reconstructions and with the denoising or artifact reduction before and reduced a bit slower. And here are the corresponding ROC curves for the 64 to 16 subsampled cases. We also did a reader study, so we tried, or we brought these images back into the clinics, showed 3 radiologists sparse sampled images with and without artifact reduction, and asked them to segment any present embolisms. And we also asked them to label the images according to quality from not diagnostic to very high, also how confident they were in the diagnosis from not confident at all to surely confident, and also asked them to rate the artifacts from like a lot of artifacts to no artifacts in the images. And here are some cherry-picked examples from this real study. So here are 3 PE positive cases. And in blue, you can see the gold standard segmentations done on the fully sampled CT reconstructions. And here are the reader results, or the segmentation results of the reader on the sparse sampled reconstructions. And in this case, all three embolisms were missed by the readers. On the first 2 cases, the embolism was correctly identified after the artifact reduction, but here in the 3rd case, even after artifact reduction, the embolism was not correctly labeled. Here are 3 PE negative cases. So the gold standard segmentation is about nothing because we don't have any embolism in there. And for the sparse sampled reconstructions, one was correctly identified as healthy, and the reconstructions here in the 1st and 3rd row were falsely classified as positive. And after reducing the artifacts, here the first example was correctly identified as healthy, but this example here, which was previously classified as true negative, was now falsely classified as positive after reducing the artifacts. And in our 3rd case here, it didn't matter if you do artifact reduction or not, it was falsely classified as embolism. And this would be, we calculated then the dice score from all the readers and the differently subsampled data with and without artifact reduction. And here in orange, you can see how the curve drops when you reduce the artifacts. So it's still still drops off when you reduce the dose, but it's better a little bit than without the artifact reduction. With this, you can also then calculate accuracy, sensitivity, and specificity, and it all. So using the artifact, the story here is it helps, but it's also like not super helpful. We also, if you remember, asked them to label our data according to quality, confidence, and artifacts. And in essence, the readers rated the artifact reduced images higher with regards to quality. They were more confident in identifying embolisms, and they also rated the images with less artifacts. But of course, especially confidence might not be a good thing. So if you look at the confidence rating of the 128 and 64 cases with unit artifact reduction, they were rated as pretty confident and somewhat confident. But when we jump back here to the actual dice score for the 128 and 64 reconstruction, we can see, okay, even though they were quite confident, the performance, the detection performance still dropped off quite drastically. So this might be something, or this is something we learned, that this false confidence might be something we have to watch out for. And we also thought, okay, how can we further improve these predictions? So in general, how this training works on a very basic level is you have your Sparse-View input, put that into your network, have the prediction of the network, and then compare that to the full view reconstruction, calculate some sort of loss, feed that loss through optimizer back through the network, and kind of update the parameters of your network and kind of fine tune the network this way. We thought, okay, this is mean-squared error, which we are minimizing. In essence, we don't really care about that one that much. What we care about is actually how well can these images be used to classify diseases. So ideally, we want to have some radiologists inside our loop who evaluates each of our images on their clinical, on the clinical usability. However, all the radiologists are asked if they would rate millions of images during a training cycle, said no, please get out of my office. So we thought, okay, maybe let's do the next best thing and use AI for that, because apparently this one is also quite good at detecting diseases. So we took our trained PE classification network, had each of our artifact reduction predictions evaluated in case of PE prediction, and compared the prediction with the actual label, and fed then back into our network, and also used some MSE loss as a stabilizing term. Well, this didn't work at all. Either the network was totally unstable when training, or the output was the same as you would just train it with MSE loss. So we thought maybe we need to get a step back. And for that, I want to quickly explain how a AI-based classifier works. So in essence, you have normally two parts in your classifier. One convolutional part, also called a feature extractor, which learns a representation of your data and kind of extracts in the first few layers very low-level features, and then kind of combines these features into a high-level reconstruction. And then after this high-level feature extraction, you kind of feed that into a fully connected network, so your classical neural network architecture, and this tells you then actually what kind of class label is associated with your input. And we thought, okay, we can maybe use these these extracted feature levels to kind of calculate the loss on those. So we took our trained classifier, again, had these Sparse-View reconstructions that input to the unit to denoise the images, fed them the prediction and the full view image into our classifier, and used this feature extraction part for that to calculate a high-level feature loss, so to say. So in essence, you could also view that as, instead of calculating the loss only in image space, you calculate the loss in kind of a in a high-level representation space of our input data. So we calculated the loss, fed that one back into our network, and trained our artifact reduction network with this. And here are the results. So on the left, you can see a full view CT reconstruction, and next to it, a sparse view reconstruction, in this case with 64 views. Here's the output when you just train your unit with normal MSE loss. And here's if you train the unit with the just explained perceptual loss. And if we zoom in here a little bit, we can see a embolism there, which is quite well recognizable in the full view image, not so much in the 64 view image, and also in the artifact reduced image by the MSE unit. It's kind of blurred out, but if you use this unit with the feature loss, you can see the features are a bit better preserved. But this is the basically the blood window, and we can also have a look at the lung window, where you can just see a bit more features going on in the lung, and you can see that when you reduce the artifacts with the unit just trained with mean square error loss, it kind of smoothes out a lot of features. But when you use this perceptual loss or feature loss, a lot of these small features are preserved. For example, this line here, which is a basically piece of tissue which separates different compartments of the lung, which is still there after the artifact reduction, but it's basically gone in the sparse sampled image and then the prediction of the unit trained with mean square error loss. So the data, so there was this P detection challenge from the RSNA, and we took the winning network and just as before, fed into the network the differently subsampled and subsequently post-processed images to see how well the images are actually for disease detection. So in the orange line here, you can see the disease or the embolism detection performance of the fully sampled images. In the pink line here, the detection performance on the sparse sampled images, which is quite significantly worse. But if you reduce the artifacts here with the MSE unit, you can see the detection performance increases. And if you use the unit trained with the perceptual loss or feature loss, then the detection performance increases even more. Okay, that also concludes the results I wanted to show about the thorax CT exams. Now I want to talk about region of interest scans in phase contrast CTs of calf lungs. So this is mostly done by Lucy Costello. And this is like the typical setup, I guess you are more familiar with than I am. So this is at the IMBL beamline at, I think, 5 meter propagation distance. And in previous work, Lucy investigated region of interest scan of these lung phantom. And what I worked with is then calf lungs, which is here hidden inside this bucket. And first also tried sparse sampling these region of interest scans, and this data was kindly provided by Lorenzo. So this was is a measurement, phase contrast measurement of calf lungs at 6 different projections, 6 different positions. And we kind of simulated Sparse-View measurements, but just reducing the number of projections and just reconstructing a reduced number of those. And as you, of course, reduce the number of projections, your image quality also drops. And then we did, in essence, the same thing as before by training a network to predict fully sampled reconstructions from the sparsely ones, which you can see down here. And if you zoom in into this red rectangle a bit, we can see even more details going on. So we can really see how the quality drops off. And when we now use these images as input to reduce the noise and the artifacts by the neural network, we can see that the image quality stays at a quite acceptable level down to 600 views. But of course, as the input gets noisier and noisier, also the network output gets worse and worse. I was fortunate enough to hop on Lucy's last beam time and measure some low exposure time measurements, again at different positions, 7 positions this time. And this time we kept the number of projections fixed at 1,800 and varied the exposure times. And these are the results. So we varied from 200 milliseconds to 15 milliseconds. And again, as with sparse sampling, our quality drops off, obviously, when we reduce the dose. However, I was quite surprised that also at like 33 or 25 millisecond exposure time per projection, the quality in the reconstruction is not that bad, even though, of course, it's worse, but still okay-ish. Because here the projections are also noisy, I wanted to go ahead and look at denoising of the projections. However, we had to discover that the high dose and the reduced dose projections don't match properly. Probably that because the sample has moved. Kind of makes sense when you think about that. It's like an inflated lung. And you move it because of the flat field measurements, and it's like moving all the time. So it kind of makes sense that it moved. However, still a bit of a pickle, since we can't do our normal supervised training anymore. So we kind of resorted to self-supervised training, and the method we tried out was something called neighbor to neighbor. So in essence, the basic idea is when you have 2 noisy images with from the same object, but with different noise, you can also train a denoising algorithm by minimizing the loss between 2 noisy images. And that is mathematically the same as minimizing the loss between a noisy and a clean image, since you assume that the image behind the noise stays the same by the noise varies. So you can also do that. And the idea from this algorithm here is that you subsample your noisy image by randomly or by distribute or having 2x2 patches of your images, and then randomly sampling 1 pixel out of each 2x2 patch. And then you get 2 subsampled images, and then you calculate or feed one of these subsampled images into the network and use the other subsampled image as target and train your network by that. And in this case, you also use a regularization term where you feed your full-size image into the network and then get your denoised prediction, subsample this, and also calculate the difference between the denoised subsampled images as a, again, sort of regularization term, because you assume that the subsampled images are still kind of similar. And we did that and trained this framework on the measured low exposure time data. So you can see one 200 millisecond projection, one of them measured 33 millisecond projections. And here is the output of the or the noised output of the neighbor-to-neighbor approach. And for comparison, we also calculated or reduced the noise by Gaussian filtering and also BM3D algorithm. And you can see that, in my opinion, at least, the neighbor-to-neighbor algorithm reduces the noise the best, while still keeping most of the features intact. But of course, you can judge that by yourself. We then reconstructed these images to look at the stereo reconstruction. So here you can see the reconstruction from the 200 millisecond scan. Here's the reconstruction from the 33 millisecond scan. And here's the reconstruction when you denoise the projections by the trained neighbor-to-neighbor algorithm. And again, while the 33 millisecond reconstruction is actually not that bad as I expected, when you denoise the projections beforehand, it's a bit less noisy, and the features are a bit better to see. However, what you still get is some ring artifacts here. You can hopefully see them in the full images, but also here you can see them slightly. So ideally, you would also use some denoising algorithms in the reconstruction space. What you also thought about was, okay, we have our noisy measurements and our clean measurements, even though they don't match perfectly. But wouldn't it be nice if we can find a noise mapping between our noisy measurement and our clean measurement, and sort of add noise to our clean measurements, and then we'd have like perfectly matching noisy and clean training pairs. And well, you could think about how to simulate the noise, but since we have kind of already the input and the target, we can also use machine learning for that and use them as a function approximator in essence. So what you did is something that was proposed by Young et al. You train a generative adversarial network. You feed in a clean measurement into a generator network. This one predicts a fake noisy image. And then you feed a fake noisy image and an actual noisy measurement into a discriminator network. And this one decides, okay, is this real or fake? And then you kind of train both images jointly, and the generator gets better and better at producing fake noisy images, while the discriminator gets better and better at finding out which image is fake and which one is actually a noisy measurement. And with that, you can train this generator to produce realistically looking noisy images, or kind of estimate this noise mapping. So we did that. And here on the left, we have the clean measurement with 200 milliseconds. In the middle, the actual noisy measurement with 33 millisecond exposure time. And on the right, we have the 200 millisecond scan with fake noise added to it. And with these noisy images, with these fake noisy images, we trained our denoising network and applied that denoising network to our low exposure measurements, which you can see here. So on the left, again, 200 millisecond projection. In the middle, the 33 millisecond measurement. On the right, the denoised version with the network trained on our fake noisy images. In my opinion, it looks pretty good. So these results are quite fresh. So I haven't done the reconstruction yet, and also not the proper evaluation yet. But these first results, I think, are quite promising that this could also work for our case. Okay, for conclusion, so in the talk, I talked a bit about artifact reduction and how this improves disease detection. And we could see that this increases automated detection and also human detection, as evidenced by our reader study. But of course, this false confidence thing is definitely a thing one has to keep in mind. Also, we talked about multi-scale perceptual losses, and we showed that they kind of, or quite improved the visual appearances of our artifact-reduced images and also improved the P detection. Regarding the region of interest phase contrast CT scans, we investigated sparse sampling versus low exposure time, and saw that both worked, even though sparse sampling reduces the quality a lot faster than just having low exposure time. So ideally, you want to do maybe okay, first of all, denoising in the protection and the reconstruction domain, but maybe also combine both the exposure times and sparse sampling to get maybe even go further down with the dose. Something I haven't talked about is like uncertainty estimation, which is of course a bit the elephant in the room. These are neural networks. You don't know 100% how exactly they work. So ideally, you want to do some subsequent analysis where the networks work, where they fail, especially in these in the image domain, because of course, when we use these images for disease detection, you have to know if you can trust them or not, and that is something I'd like to explore a bit in the remaining time I have here. And with that, I'd like to thank you all for your attention, but also thank some additional people, because of course, research is most of the time not a single person effort, but a group effort. And I'm very lucky to now have two groups with a lot of amazing people I can talk to and find help in case of problems. And the first group, of course, is my group at home in Munich, the chair of biomedical physics at TUM, but now also the X-ray imaging group here at Monash University, which welcomed me so warm-heartedly, and I'm very thankful for that. And that concludes my talk. Thank you very much.
Thank you, Johannes. Beautiful talk. So many nice ideas and results. Do we have questions from the audience? Ashkan, go ahead.
Hello, thank you. Great talk. I was curious about your perceptual network, your perceptual loss, and what network you had used to calculate your perceptual loss. And sorry, I missed it and you said it.
I think it's on the slide, but I didn't say it specifically, so no worries. So I used the VGT19 network, and here. Yeah, so basically VGT19, because it's quite used a lot in this kind of losses. I did some experiments also with the FissionNet, didn't work so well. I don't know exactly why, so I kind of switched to VGT19 because it's kind of easier to understand what exactly is going on. And then since it worked quite okay, I didn't actually try out different architectures.
No, I was curious the data it was trained on, sorry.
The data, not the network. So this was trained for disease detection on the data for the RSNA PE detection challenge.
So it's the same data. Is it the same data that you was effectively trying to convert in the Sparse-View?
No, it was a public data set and fully sampled data. So no sparse sample. So yeah, trained on fully sampled data for PE detection on the public data set.
So it's a completely different data set to what you were
exactly.
Okay, great.
Exactly. Yeah.
That's what I was most curious on. And I was also curious if you sort of consider on the slide before where you showed different results of this network, and was before or after, sorry. You showed the different results.
This one.
Yeah, I think so. Yeah, I was curious on what you think, to what extent sort of all this parenchyma detail that is added is real, because I was trying to compare it to full view, or if it to some extent tries to, you know, as it is a perceptual loss, it's trying to make it look more like there's something there, but it's not necessary.
Yeah, very good point. Kind of glossed over that a bit, I guess. So for example, if you focus on these small vessels over there, then they look a bit different. this image here, right?
Yeah.
Again, if you look at the Sparse-View reconstruction, you kind of cannot blame the network. But of course, it looks very realistic or very high quality, even though it's not. Obviously, this is an issue, for sure. But on the other hand, the images are like for disease detection, in this case, pulmonary embolism detection. And what we then kind of tried to show is, okay, if these images still are better in detecting these diseases, it kind of justifies the cost, so to speak. But of course, yeah, that is something which absolutely must be considered. Yeah.
Okay. Thank you. That's all.
Patrick, please go ahead. Oh, I think you're still on mute.
Thank you, Johannes. And as Kay said, it truly was a beautiful talk. You navigated us through lots and lots of different studies in an incredibly effective way. So well done. I have plenty of questions for you, but I'll just try and narrow them down to just one or two. I just coming back to Ashkan's comment there. I think that UNet versus the feature loss UNet. Certainly, I think the ROC showed, if I'm not mistaken, that it was improved for the feature loss. But coming back to Ashkan's point, I've just again wondered whether that was artifact or real, and did you actually have a chance to look at false? Was there a human observer evaluation here, or was this AI? I can't remember about this one.
Yeah.
Okay, it'd be very nice to see with humans, how they, if there was an increased number of false positives in the normal tissues and normal cases here, to see just to eliminate the fact that this might be artifact. It's a bit like MRI for breast, for example, has incredible sensitivity. It'll find the lesions, but it introduces so much stuff into the image that the specificity is much lower than mammography, for example. And I'm just wondering if you possibly could see that same effect here.
Yeah, I agree. So doing a reader study would absolutely be interesting. Maybe when I'm back in Munich, I'll have time to bring these images back to the clinics.
Okay, well, let us know. I'd certainly be very interested to know. I think just a couple of the general points. It's quite rare what you've shown us, because you've actually, to try and test the value of your interventions, you've actually gone down the AI approach, and you've also gone down the human observer approach. Like we have, it's been the bane of our lives for years, finding enough human observers to look at these cases and so on. Is there anything you lose by having an AI solely approach? I know you looked at confidence and quality and stuff like that. I'm just wondering, are those sufficiently important for us to insist on having human observers when we're testing these interventions?
Yeah, I think so. Because if you do the AI-based classification approach, we have seen that these artifacts kind of reduce their results quite a bit, while we humans are quite good at kind of interpolating and realizing, okay, this is an artifact. I don't focus on that one. So, and in the end, of course, these images are medical. So you're gonna have, if you want to have the system in the clinics at one day, you're gonna have a radiologist look at it. And this is kind of like here's kind of last say on what the detected disease is. So they must be well suited for them to detect diseases. So to answer the question, I think that's kind of the benefit of having a human in the evaluation loop, that in clinical practice, you're also going to have a human. So you should know how that affects them.
Okay, thank you. And just one very last quick question, if I may. It was your own AI classifier you built, wasn't it? For the lung.
For the lung, yes.
Yeah.
So I mean, wait, for the long. I mean, we trained them ourselves. Sorry,
Yeah.
a little correction. We trained the classifier ourselves, but the architecture was taken from this detection challenge, where we looked at the winning network and they released the code, and we took the code and trained that again on the data.
Okay. We've got quite some strong links with commercial AI classifiers here, particularly in Australian AI. Annalise AI, for example, is based in Sydney. So if you ever wanted to run your images via a commercial AI, that might be possible.
Oh, yeah, that sounds
you.
very good.
Okay. Thanks again.
Thank
A
you.
really good talk.
Thanks, Patrick. Perhaps I could have a question. You were framing the false confidence potentially as a problem, and it reminded me of some of the work done by your colleague Henrietta Bast, where she was using dark field imaging to detect a pneumothorax, and she found that the dark field was not more accurate than the conventional images, but it was much faster for the radiologists to decide. And actually, both the radiologists and the hospitals and the funders care about fast diagnosis. Do you think that having more confidence from AI images might be of benefit in terms of speed of diagnosing?
Probably, I guess. Hard to say how correlated confidence and speed are.
Yeah.
If I would have to guess, I would say probably correlated, but I don't know. So yeah, but also be interesting to kind of time such reader studies and then also have a look if faster diagnosis is something that separates different modalities.
But perhaps a less noisy image makes for a faster diagnosis.
Yeah, maybe, yeah.
Any final questions before we wrap up? No? Well, thank you everybody for attending, and thank you very much, Johannes, for a very thought-provoking and interesting seminar.
Thank you.
Thank you.
Thank you. See you next time.